recording. There we go. Well, hi and happy Tuesday. It's September 23rd for those of you who are listening on replay. Today, I'm going to be talking about menopause, how we got into this kind of messy situation where people are confused about hormone therapy. Is it okay to use? How do we use it? And what's kind of the history that got us here? So this informal topic is menopause. What the heck is happening? Menopause has never been a more talked about subject, and I want to give y'all some history of that. This will be the first of several weeks of talks about this. What I want you to walk away with today is one, kind of how we got to this current understanding of safety around menopause hormone therapy and the menopause transition, and two, some information basically about primary care prevention. So there's lots of big talks that are happening on social media, experts all across the country, books that are being written, podcasts, et cetera. I will point you towards some of those resources in the end, but from my lens as a primary care doc, what do I think about in hormone therapy? Who is it appropriate for? And what are we doing to prevent disease and improve health span over life? I'm an internist in Atlanta. I primarily do eating disorder care, menopause care, and this Ehlers-Danlos-Potts mast cell disease triad. I'm a certified menopause practitioner, and I've been taking care of folks with menopause for a long time. Disclaimer, I'm a doctor, not your doctor. Talk to your medical team about medical decisions. So historically, we would think of, the time that we start our period, the time of puberty, menarche, we call it, until the time that we stop getting our period as this normal reproductive years, right? So the average age for menopause in America is 51, 52-ish. 90% of women go through menopause between the ages of 45 and 55. And then after we stop getting our period, after our last period that we get, most people will describe that as like post-menopause. That's like the general overview, but it's a little more complex than this. And this is really reflecting people's lived experience. This term perimenopause is exactly that. It's around the time of menopause. The line in the sand is your last period. But for white women, we know that perimenopausal symptoms can start about 6 years prior to the last period. For Black and Hispanic women, it's closer to 10 years prior to your last period. So if on the early end, people are going through menopause around 45, it's not unreasonable that in your mid to late 30s, you may start to have some early symptoms of perimenopause. And conversely, after you get your period, it's not like the light switch turns off and magically you're feeling fine again. There's a period of adjustment that happens. So this whole menopause transition, or perimenopause, from 40 to 55-ish, depending on your genetics and racial background, we call perimenopause. But often what women are coming to me for is this premenopause, meaning like, I'm in this early phase. I'm starting to feel these symptoms. I just don't feel like myself. My brain's not working. I'm having hot flashes. My mood is all across the board. My body hurts. I just don't feel like myself. And this is really what is prompting a lot of visits to doctors' offices. And we'll talk about how that is managed in just a minute. There's some basic terminology I think is important to know. So-called, quote, natural menopause or biologic menopause is exactly that. It's your last period and it's been 1 year since your last period. Now we say you're officially in menopause. There's a term called surgical menopause, which is exactly what it sounds like. You do not have pelvic organs, meaning someone's taken out your uterus. So you cannot bleed. And so that's surgical menopause. Even if you still have your ovaries and your ovaries are still cycling, you're not going to bleed because you don't have a uterus. So that's surgical menopause. And then chemical menopause is when we've effectively poisoned the ovaries through things like chemotherapy or other medications so that the ovaries stop doing their job. So you may still have a uterus, you may be younger than 45 years old, but your ovaries are not performing. So chemical menopause is the terminology for that. Either way, they all have symptoms and it's worth evaluating. This is a very short list of some of the symptoms that you may experience with menopause, but the point of the graph is to point out that the so-called vasomotor symptoms of hot flashes and night sweats are by far and away some of the most common stuff that we're seeing. Depending on the data you're looking at, 70 to 80% of women, certainly more common in women of color. But across the board, we're starting to see that. I mentioned mood changes and difficulty sleeping. There's tons of pelvic symptoms or genital urinary symptoms of menopause, syndrome of menopause. joint pain, which is musculoskeletal syndrome of menopause, brain issues, bladder issues, etc. So we have estrogen receptors in every tissue in our body. And so we are going to see quite literally head to toe symptoms. This is not hysteria. People are not just, needing to toughen up and just keep moving forward. These are real symptoms that interfere with our quality of life and our longevity and need to be addressed. It's not just hot flashes, like I mentioned, from head to toe. Every organ system can have some degree of impact from hormone changes, but the ones we most commonly talk about are the brain fog, specifically word finding, memory loss, inattention. People are coming to me saying, I think I have early Alzheimer's. I think that there's a problem with my brain, when really it's just estrogen deprivation. We certainly know that people can have cardiac symptoms. Oprah quite famously went to 4 different cardiologists for chest pain and palpitations until she was finally started on hormone replacement therapy and her symptoms went away. We certainly have mood disturbances, which I'll talk about, but certainly the irritability, everyone is driving me crazy, increased anxiety and depression is part of it. Lots of digestive issues because of the impacts of hormone on gut motility, with bloating and constipation and fluctuation in bowel habits. There are physical joint-related symptoms like frozen shoulder, plantar fasciitis, tendonitis that tend to become more common in this. So across the board, it almost feels like you could name a symptom and someone can trace it back to menopause. But it is a real transition because the basic fabric of how our body's behaving is shifting during this period of time. So often patients come in and say, well, can I just check my hormones? I want to see where I am in this process. And so this is a normal physiologic curve of what is happening with hormones. I don't expect you to be scientists around it, but what I think the take-home message is that there's lots of variation in these different hormones. So up top, we've got the brain hormones, your FSH and LH. They send signals to your ovaries saying, hey, you need to make a follicle, release an egg so that we can create more humans in this world. And so that signal, as your ovaries start to decline, actually gets louder and louder. And so you'll see more kind of exaggeration of these peaks. And then down below, these are your ovarian hormones, both progesterone and estradiol. So depending on where you are during the course of your cycle, you're going to have predictably varying levels of hormone therapy. So when people say, can I check my hormones, especially if your periods are not regular, you can see that on like day 6 of your cycle, your hormones are going to be kind of low. But if I check a week later, they may be high, or they may be even higher than we anticipate because the body's trying to overperform as the ovaries are declining. So if you've ever had a doctor say it's not helpful to check hormones, this is what they mean. They're going to vary throughout the course of the month. If you knew exactly where you are in your cycle, sometimes we can, roughly gauge that. But the chaos of these hormones in the background, the fluctuations that we anticipate seeing, sometimes make it harder to interpret. And at the end of the day, you can still be getting a solid every single month period and have widespread perimenopausal symptoms. So as it turns out, talking to my patients is the most effective tool that I have to say, tell me what you're feeling and experiencing, and let me help you find some tools for that. We don't necessarily base our hormone dosing based on blood levels. There are some exceptions to that, but generally in the perimenopausal period, we do not. This is a slide to kind of give you some background on hormone replacement therapy. This is not a new thing. It's been around for well over 80 years. In 1942, the initial hormone therapy conjugated equine estrogen, and that is quite literally pregnant horses. They excrete a variety of different estrogen compounds in their urine, and that is isolated and collected and made into a pill for humans to take. Pregnant mare's urine. And so they named it Premarin because someone thought that abbreviation was cute. So Premarin was introduced a long time ago, literally pregnant horse pee urine, estrogens. And so that was given to women and they actually felt great. And by the way, this medicine is still on the market and it's still appropriate in some scenarios. So you can still actually get your hands on this, although we're using it less commonly. But what we found was that when we gave people with a uterus estrogen by itself, their risk of endometrial cancer went up because the uterine lining was not being protected by progesterone. So a study came out in 1975 saying, hey, we're actually creating harm with this. We're creating endometrial cancer. And so very rapidly, people stopped prescribing that estrogen hormone therapy. And about 5 years later, they realized, if you give someone estrogen and progesterone together, it protects them against endometrial cancer. So yet again, we saw hormone therapy dosing go up. There's a couple of landmark trials that I won't get into, but in short, where we are now is a big, big trial of 161,000 women that was released in 2002 called the Women's Health Initiative. And they looked at women who were on this combination of equine estrogens and synthetic progestins, not the same thing that your body naturally makes, but progestin. And they found that when they looked at this population of folks, that their risk of blood clots, cardiovascular events, and breast cancer increased. And so it was on national news. They stood up and made this big announcement, like, these hormones are really bad for you. And very rapidly, we saw a massive decrease in prescription of hormone therapy, and more importantly, education of physicians and other clinicians on hormone therapy and menopause. And so this is where we find ourselves now, in this kind of valley where, my generation of physicians, solidly mid-career, like, I was in second year of med school when this came out, and we were taught, like, hormone therapy is really dangerous for women, don't prescribe it. And so this generation of clinicians that are out in the workforce just simply were not taught how to prescribe these. And so if it feels hard to get accurate information and different doctors tell you different things, it's because of this educational deficit that happened. This is a very busy slide, which I did not expect you to be a statistician to read, but it's a reminder for me to say there is a huge amount of data that has disproven that trial that I just mentioned. And most famously, in a couple of years back, they went back and looked at that very same data with the very same patient population and looked at the ones who got conjugated equine estrogen, so that horse pea estrogen plus the synthetic progestin combined. And then they looked at different age groups, 50s, 60s, 70s, and then they compared that to people who just got estrogen alone, same 50s, 60s, 70s. And they looked at the very specific diseases that they talked about: coronary disease, breast cancer, strokes, blood clots to the lungs, etc. And what they found, the black lines are people who got it, the white lines are people who did not, is that the risk of getting these diseases in people who just got the estrogen were lower. In other words, estrogen was preventive for the very things we were worried about: coronary artery disease, breast cancers, strokes, colorectal cancer, and all-cause mortality. People were living longer on estrogens alone. So this has really informed our current understanding that it is the synthetic progestins that actually caused the issue that we were worried about in that trial over 20 years ago. And so we've done many, many, many trials, many different observations looking at this stuff, and we really do believe that hormone therapy can be safe, effective, and preventative. And so from my role as a primary care doc, trying to prevent disease in the long run, estrogen hormone-based therapy is a tool for that. We've got some Q's and A's. Yes. Okay, I'll answer that question in just a second. All right, next. Okay. Oops, there's nothing on there. Okay, so when we talk about the actual hormones that we use, there are three main ones that you'll hear people talk about. There's estrogen, which estradiol is what your body makes, and it's metabolized into a different form called estriol, but estradiol is the most common one. This is literally what your body makes, and it can be replicated in a lab and made into a medication that you can buy at your local drugstore. So if you're going to get hormone therapy at your drugstore, this is literally what that is. Progesterone is the other, which is micronized progesterone. This is the same thing that your body naturally makes, not the synthetic progestin that was incriminated in the slide I just showed you. And then lastly, good old-fashioned testosterone is testosterone. And so if you hear people talk about, well, I don't want those unnatural hormones, I want bioidentical hormones, I'll just candidly say that this is a marketing tool. You do not need to pay a ton of money to have hormones injected into you or compounded, etc., to get exactly what your body needs. The ones that are coming from your drugstore are bioidentical, and good old-fashioned estrogen pills are $4 a month. So there are so-called bioidentical, same as your body makes, medications that you can get through your insurance. And what we know matters is that not every hormone does the same thing. I think about it like an a la carte menu. have to figure out what my patients are experiencing and how I want to treat that. And then how do I want to deliver those medications into their body? So this is just estrogen alone, just as a smattering. Next week, I'll talk more about the uses of these various different compounds, but you can take a pill, literally a pill once a day. You can do a patch, which is the most common one that you find people prescribe because it does not go through the gut. You can do a vaginal estrogen cream that just works locally and doesn't have any systemic absorption. You can do an injection, this is probably a least common one that we use. All of these are FDA approved. All of these are bioidentical. You can buy them at your drugstore. And then lastly, you may hear people talk about pellets, which is a compounded little tablet that's injected under the skin and that will last 3 months. This is not FDA approved. And people have polarizing opinions about this. But in short, there's lots and lots of different choices, and using the right choice for each individual really matters. So why would I consider giving these medications to patients? Okay, so we talked about just quality of life issues. It is not, it's not lost on me that women in their 40s, more or less, are in the sandwich generation with aging parents, children who are growing up, career advancement and peak issues. So there's lots of stress, lots of different changes. And in the midst of all that, when they're supposed to be on their A game, their body is falling apart. And as a result of that, often people end up overworking and overpreparing, trying to overcome their body's symptoms. And when people go to the doctor specifically to say, hey, I just don't feel like myself, I don't feel good, only about 20% of women who actually have these perimenopausal symptoms will actually get a prescription from a doctor to address them. And of those folks who actually get a prescription, 5 to 1, they're given anti-anxiety or antidepressant medications, which, as it turns out, and I say this as someone who prescribes those medicines on a daily basis for true mental health disorders, they do not fix menopause hormone therapy. They may mitigate some of the symptoms, but they actually may make some of the stuff worse. So we're not treating what's really happening in the background. So quality of life is a big, big deal. And if you do not care about the well-being of women, you should at least care about their financial impact in our society. We have studied this, and we look at women in the menopause range and their impact on performance in the workforce. They are more likely to miss days of work, which creates pay gaps. They are more likely to make errors, not for lack of effort, but because their brain is not working as well as they'd like it to. And so this cumulative loss creates about $1.8 billion of lost revenue in the United States alone. So if we want to have a financially secure country where people are able to contribute at their highest level, we have to start addressing this as a societal issue. This is not women just not trying hard enough, believe me. So quality of life is a big deal. Okay, so for those of you who were here a couple of weeks ago listening to the talk on like how to make the most of your physical, you can go back and look at that video. When patients come in to see me to say, hey, I'm here for my physical, what do I need to be thinking about? I think about these things in buckets. So one is, how do we prevent heart attacks? And so in the world of cardiovascular disease, as people start to lose estrogen, their blood vessels themselves do not behave the way that they're supposed to. They may become stiffer. They may have fluctuations in dilation, which causes hot flashes. We also see that there's a direct impact on their cardiometabolic risk factors, like your cholesterol and your insulin and your glucose. So I cannot tell you, for the past 20 years, I've had women say, I'm doing exactly the same thing that I've always done. I'm exercising, I'm trying to eat well, but now my cholesterol and my sugars are through the roof. What happened? And I think it's easy to look and be like, well, maybe this patient's not trying hard. No, that's not what's happening. They're having hormonal fluctuations that's causing that outcome. And what we know is that the earlier you go through menopause, especially if you're earlier than 45, every year before 45 that you go through menopause, your increased risk of having a heart attack or having a cardiovascular event goes up by 3%, which 3% is not that bad. But let's say you had breast cancer in your 30s and you've been off hormone therapy since 38. I mean, your risk really does add up over time. So we know that when we put people on estrogen, just like that trial with all the busy slide I showed you earlier, it reduces their risk of having a heart attack because of these mechanisms. And so it is not currently in the guidelines from the big heart associations in America to say, hey, everyone needs to go on estrogen to lower their cardiovascular risk. But I promise you that there's a very loud contingency of physicians who are saying we need to add this to the algorithm so that people know that there is a benefit to going on hormone therapy. Cardiovascular disease is the #1 killer of women in America, so this is not a small issue. It impacts all of us. So that would be one reason for me to consider it. Secondly, genital urinary syndrome of menopause. Okay, this is, I think of it like a Venn diagram of these 3 different areas. There's urinary symptoms, like our pelvis itself. We've got our bladder down there. So urgency, frequency, burning when you pee, feeling like you always have a UTI. There's sexual symptoms, which is pain with intercourse, lack of lubrication, and loss of orgasm. And then lastly, there's also just symptoms externally, like burning, irritation of the genital area, etc. And so I mentioned that there's a cream and a tablet and a ring. We'll talk about those next week. There's vaginal estrogen products that address all of these things. And there's an amazing clinician up in DC, Baltimore area, Dr. Rachel Rubin, who has studied this. And when we look at the Medicare data for women who have experienced UTIs and the cost of that, it was like $1.4 billion a year of Medicare spending that could be absolutely prevented with a $13 tube of cream of estrogen. So this is more than just, oh, it's annoying that I have to like map out all the bathrooms in every store that I go to. There's outcome issues, there's mortality issues. You think about grandma who's like got a UTI and then she starts acting a little kooky and then she falls down and breaks her hip and then it becomes this like life-ending illness. This is where that all starts. And so as the pelvis itself starts to have deprivation of estrogen, we see it across the board. And so if I want people to stay healthy, to maintain their bones, to not fall, to be able to avoid life-threatening infections, the use of hormone therapy is appropriate. There's an active call this week to talk to the FDA about removing the black box warnings on vaginal estrogen creams. If you're listening live, please go check that out. And it's a way for us to voice to say this medicine is so safe, it should be available over the counter. So this is another prevention. Next, bones. So we know that the times where women are most likely to lose bone density are in the first 2 years after their period stops. So we typically screen for osteoporosis like in the first 2 years after someone stops getting their period. So the use of estrogen helps maintain bone density. We don't use estrogen to treat osteoporosis, but it certainly has a role in prevention of bone loss. And so the earlier we start these medications, the better. Particularly for folks who have gone through premature menopause, making sure that they've got hormones on board is really helpful. Oops. Mood disorders. I ran out of time to put pictures in here, but you can just picture whatever you want to picture. If you have baseline anxiety and depression, we know that your risk for those getting worse during the perimenopausal period is there. We know that people often have new onset mood disorders, whether it's just general irritability or true anxiety depression that can show up in that window of time. We know that for women who die by suicide, the most likely time in their life to die by suicide is between the ages of 45 and 55. And like, what did we think was happening in the background? They just got, like overwhelmed all of a sudden? No, like our brains desperately need this hormone in order to maintain homeostasis. So mood disorders are a big part of our general wellness. It impacts our physical, emotional, spiritual, and other forms of wellness. I mentioned, what happens in the workplace if mood is an issue or you're not able to concentrate, et cetera, it impacts our careers. And so when people go into the doctor saying, I just don't feel like myself, I'm really moody, I'm really agitated, I understand why one might prescribe an anti-anxiety and antidepressant medication, but we should absolutely be thinking about, is estrogen therapy appropriate for these folks? And then lastly, dementia. We know that there's several different types of dementia that's out there. We know that with Alzheimer's type dementia, going on hormone therapy, the earlier the better, reduces your risk of developing Alzheimer's by about 15%. There's another form of dementia called vascular dementia. It's from lots of mini strokes. And I mentioned the cardiovascular data earlier. So if we can prevent cardiovascular outcomes, specifically like vascular dementia, then that's another way that we can prevent it. So for me, as someone who values my brain, this is probably the most compelling thing for me. Like, I want my brain to work as well as it can for as long as it can. I want my body to be healthy. I want to reduce my risk of having a heart attack. I want to make sure my bones are strong. I want to make sure my mood is good. And so there's a lot of reasons that I might advise a patient to consider hormone therapy. So who should not use estrogen, right? We like to paint it as this panacea that's going to cure everything. Who should not use it? So one, if you have an active, ongoing estrogen-driven cancer, right? If you have active breast cancer or endometrial cancer, yeah, giving it fuel to the fire is not a great idea. If you have an active blood clot, especially if you have a known genetic disorder that increases your risk of clotting, estrogen, especially oral estrogen that passes through the liver and increases your risk of clotting, is not a great idea. There are some exceptions to that rule, but as a general rule, that's where we are. If you are really high risk of stroke or have had a recent heart attack, these are equivalents of clotting. People will be pretty reticent to give you estrogen in that window of time. And then lastly, if you've got liver disease, particularly like estrogen-driven tumors in the liver or cirrhosis, then people are not going to be excited about that. But I think what we're finding as we start to really dissect this data, for example, I have a patient who had breast cancer 10 years ago. She's had a total hysterectomy and had her ovaries removed. She does not have breast tissue. She's had a bilateral mastectomy, and she is absolutely debilitated by her menopausal symptoms. She definitely can be on vaginal estrogen. There is no systemic absorption that I'm worried is going to drive cancer. But in her case, an informed decision process with someone who can really go through the data to say, you don't have any breast tissue, you don't have any endometrial or ovarian tissue. Looking at an informed consent process and quality of life, I think, is a really big deal. And she had seen multiple different docs and heard a lot of different things. But at the end of the day, she said, I would rather have a life that's worth living than be this miserable for whatever years I have left. And so she decided to go on hormone therapy. So I think you're going to see a lot of different exceptions to these rules as we move forward. In terms of resources, right now, please subscribe to my channel. But also, if you go to Dr. Rachel Rubin, who's the researcher that I mentioned earlier, she's got amazing, amazing work, particularly on the genital urinary syndrome of menopause. She has tons of information on her YouTube site. Go follow her. And then Dr. Kelly Casperson particularly looks at sexual health in the perimenopausal range. She's got an amazing book called The Menopause Moment and a podcast called You Are Not Broken. And she's also on YouTube. So these are people absolutely worth following for more information. If you are looking for a doctor who understands menopause, you can go to the Menopause Society's webpage, which is menopause.org, and find Menopause Society certified practitioners like me. Actually, I looked and I'm not on the website, but anyway, I'm certified. So that's an easy way to find people in your zip code who specialize in menopause and should understand this work so you can get the care that you deserve. And then lastly, if you have any questions, I'm happy to answer them. Please sign up for my email list so you can get updates on future videos. Or if you're looking for a doctor in the Atlanta area or licensed in one of the 17 states where I am, I'm happy to see you as a patient. Thanks so much.